This is the information from week 3, chapter 19, and it's quite a lot, almost 80 slides, so I might break it up a little bit. But this is everything that we need that's actually from the PowerPoint. So we'll get started with this. Arteries. We start at the heart, and arteries take blood from the heart. We start with the heart, arteries, arterioles, capillaries, then venules, and then veins, and back into the heart again. Capillaries are where the exchange takes place between the cells. Every single cell in your body has to be adjacent to a capillary to be well. And that's where the gas exchange takes place. So in the lungs, to get what's fresh, and in every cell to pick up the waste and deposit what's good. Here, enlarge this if it's possible. As the blood leaves the heart, represented in red, the arteries, and goes through to the arterioles and then to the capillaries. Here we have represented cells of the body and capillaries there. And these capillaries are single cell thick, and the little bubbles here represent cells of the body. They have a whole universe of work going on in each cell, all kinds of things going on. Every year we learn more of what's happening in the cells. There's a lot of waste, a lot of trash has to be taken out, and carbon dioxide. So this is diffused into the capillaries, and then the excess, the higher concentration of oxygen goes from the capillaries into the cells. So the cells can stay healthy. This actually, the transference is greater when a person is active. So walking and moving around is a great help with keeping your cells fresh. How does the blood get cleaned up then? The blood will go into the lungs. Okay, from the heart, it goes back into the, pardon me, the heart and to the lungs. And the capillaries in the lungs are connected to these alveoli. The alveoli are the very, very end, like the leaves on the trees. The air comes into the lungs, and it comes the trachea, the bronchioles, and smaller these trees until it gets to the alveoli. So we've inhaled about 21% oxygen, and providing we're not a smoker. And so this oxygen is in the capillary, and it diffuses, or in the alveoli, and it diffuses into the capillaries. And the capillaries are high in carbon dioxide, so that diffuses into the alveoli. So when we exhale, we get rid of that carbon dioxide, and then we inhale and get new oxygen, and this continues the circuit repeatedly. Okay. Look at this. Two sides to the heart, of course. I think there are two sides to everything. But the right side receives the deoxygenated blood, the blood that came from those cells, all of them in the entire body, goes into the heart. And then it's pumped to the lungs to get new oxygen, just like we went through in the image. Then the left side receives oxygenated blood and then pumps it to the body. The heart has 4 chambers, 2 atria, 2 ventricles. The atria are receiving chambers, and then the ventricles are pumping chambers. Okay, so into the right atrium, and then out to the lungs, into the left atrium from the body, and then out, left atrium, and then out to the body. Okay. The superior vena cava and inferior vena cava, they bring blood to and from the heart chambers. They drain deoxygenated blood to the right atrium. Sorry, I'm like, how'd that go? They drain deoxygenated blood. So it's blood from the body into the right atrium. The pulmonary trunk transports blood from the right ventricle, splits it into pulmonary arteries. The pulmonary veins drain oxygenated blood to the left atrium. Now, the pulmonary circulation is the only time that veins carry oxygenated blood. Okay. The aorta transports blood from the left ventricle. The great vessels, those are the main ones. The superior and inferior vena cava, the aorta is here. These major vessels, they are great vessels, they're major vessels. They continue down behind a woman's uterus. Okay, so if she's with child, great. If the fetus is getting large, it can, if she's laying on her back, it can put weight on these two vessels and inhibit blood flow. So the woman who has a larger fetus, she should lay on her left or her right more, not on her back, for better circulation. Okay. Capillary muscles, chordae tendineae, cusps that make up one of the valves. Okay. Semilunar valves. Okay. Like two moons, a moon and a moon, semilunar. All right. The heart has two sets of valves. They make sure that the blood only goes one way through the heart. If the blood doesn't keep going, sickness ensues. If the valves leak, that's a great problem. The atrial ventricular valves, atrial ventricular. So it's between the atrium and the ventricle. And the right one is a tricuspid, and the left one, the bicuspid or mitral. Names hang on for decades and decades. So it keeps it interesting. Maybe it's a mitral, maybe it's a bicuspid. They're the same. Semilunar valves, they sit at the boundary of the ventricle and the atrial trunk. The pulmonary semilunar valve is between the right ventricle and the pulmonary trunk, and the aortic semilunar valve is between the left ventricle and the aorta. What I like to do when I'm learning new geography in the body is to have an image, whether on a tablet or a paper or something, and then go through it with my eyes or with my fingers to just review, how is this working? So here we see the semilunar valves. And this makes sure that the blood goes up and can't come back. And this one also, the blood goes up and can't come back into the ventricle. Again, the atria are here, and we have the left AV valve and the right AV valve, held from flipping the wrong direction by these cords and muscles. Pulmonary circulation, the circulation that goes to and from the lung, the deoxygenated blood from the right side of the heart to the lungs. The lungs, the blood picks up the oxygen, like we looked at in the first image, releases carbon dioxide, and then returns to the left side of the heart. Systemic circulation, oxygenated blood from the left side of the heart to systemic cells. Those are cells all that make up your entire body. Everything needs the resources to do its job. It needs those nutrients. It needs that oxygen. Systemic cells like skin or muscles or any other cell of the system, the blood exchanges gases, nutrients, and waste, because remember, each cell, that bilipid layer, there are channels and sometimes there's diffusion straight across. Okay, so entering and leaving that cell, and then that simple squamous single cell wall of the capillary, so diffusion takes place. Gas exchange, nutrients, waste, blood vessels return blood to the right side of the heart. And then we start over. The right heart, lungs, left heart, systemic tissue, and then right heart, and it repeats and repeats until we die. This is a good image of where the heart is. And here's the apex, the point, down at the bottom. Right ventricle, left atrium, right atrium, right here, right behind the manubrium, this bone, and then the xiphoid process, this bone, but in front of the vertebrae. These will be thoracic vertebrae behind here. You can see the aorta coming up. Okay, for placement. The left lobe, 2 lobes of the lungs are here, where the heart tucks in. On the right side, the lung has 3 lobes, so not so much room for a heart over here. Here's a diaphragm. The diaphragm is very important. Very important. The diaphragm is a muscle. When you inhale, it flattens down, and when you relax, it comes back up, and the air is pushed back out of the lungs. So we inhaled our 21% oxygen, and we exhaled our 17% oxygen. And the difference went into our system. 3 layers that the heart's enclosed in, the fibrous pericardium. And this is dense, irregular. When you hear fibrous, it's very strong, okay? Some of it's considered avascular. It attaches to the diaphragm on the base of the aorta and the pulmonary trunk, anchors the heart to prevents its overfilling. And we'll talk about that part in a minute, but the heart needs to be anchored well. And fibrous tissue is what the body uses to anchor things. The parietal layer, parietal, of serous pericardium, this is simple squamous epithelium again, single layer, flat epithelial tissue and areolar connective tissue. It attaches to the fibrous pericardium. The visceral layer, visceral always is on the organ itself. The visceral layer of serous pericardium is, again, a single layer of cells that are flat and areolar connective tissue and attaches directly to the heart. 2 serous layers, continuous and separated by a pericardial cavity for protection. Here you can see this layer that can have lubricant. It has lubricant in it. So as the heart pumps and pumps, it doesn't chafe and rub and inflame. Okay. It's bigger up here. You can see this layer with lubricant, pericardial cavity, serous fluid. And then out here is the very strong and tough layer of serous pericardium. It's fibrous tissue. Right sitting on the heart is the visceral layer. Visceral is on the organ, not just the heart, but any organ. Okay. Good view of papillary muscles, chordae tendineae, cusps, atria, ventricles, this thick muscle on the side that needs to pump through the whole system, through the whole body. Semilunar valves, thinner muscle. This chamber is only going to pump to the lungs. Okay, to the lungs. Apex, you can see this fibrous tissue connecting to the diaphragm. And what is this? Interventricular septum. Okay. And what is this? What is this one? And the inferior part. And what is this? The same as this. Okay. All right. Atria from the outside here called auricle a lot of time because it looks kind of like an ear. So there's an auricle on each side. Those are the atria. Here you can see the coronary vessels. Okay. Right coronary artery. If these get occluded or blocked, and I have an image coming up, if they're blocked and blood can't go through, then some of the heart tissue has no fresh oxygen coming and can't get rid of its waste, so it begins to die. Okay, so if you see hear of someone getting a coronary artery bypass, that's this. They will get a vessel from somewhere else and make an anastomosis. They'll make a Y and let the blood go through to feed the rest of the heart so it doesn't die. You can see a good image here of the coronary sinus. A sinus is a hole. You know, we have sinuses here that we're used to, and sometimes they get in them, you know, and then we sound different, and there's, you know, mucus in there. But a sinus is a hole, and here's an image of the coronary sinus, usually hidden behind, and the superior vena cava going down into the inferior vena cava, and the atrium, or the aorta, pardon me, aorta will come all the way down as well. The descending aorta will continue. Ventricles are the pumping chambers. Atria are the receiving chambers. The left chamber needs to generate high pressure to be able to push this blood all the way from the arteries, arterioles, and capillaries. There's another way the blood keeps flowing later. We'll talk about past that, but that's where these, the left ventricle has to push the blood to. The right ventricle pumps the blood to where? To the lungs. Yeah. Okay. So it's thinner. All right, 3 layers of the heart wall. Epicardium, epi means covering or above. Epi, so it's the outside. Cardium pertaining to the heart. Visceral, pericardium, so it's on the heart. And then there's the myocardium. The myocardium is the actual thick muscle that we were just looking at. It's the muscle wall. The endocardium is a lining on the inside of the heart, and it is continuous, the inside of the heart, with the vessels, so the blood can flow freely. Here's an image. You can see the endothelium, endocardium, endothelium, okay? Simple squamous epithelial tissue. The myocardium, the actual muscle, okay? Heart muscle is the only muscle in the body that has intercalated discs. Okay, and then there's the epi covering the outside epithelium. Simple squamous, 1 layer, flat. And here you can see there are vessels in this adipose tissue, the fat. But this is visceral fat. And this visceral fat is the fat that's dangerous. This is the fat that Americans are getting more and more of as they're getting heart disease. It's not caused by eating fat. It's not caused by eating meat. And here's another, but it's reminding us that itis is inflammation. Endocarditis is itis of the inner lining, inflammation of the inner lining, and pericarditis, the whole, and myocarditis, the whole thing. So the myocardium, the endocardium, you can get inflammation most anywhere. Separation of chambers, there's an intraatrial septum and the interventricular septum. Septum means wall. And so the interventricular septum is a wall between the right and left ventricles. The right atrium contains pectinate muscles. These are ridges on the anterior wall inside the auricle. Now, this is a little different. The fossa ovalis is an oval depression on the interatrial septum. This is from where the foramen ovale was in utero. The fetus had blood movement between the right and left atrium in fetal life. Okay. So that's where the fossa ovalis came from. That closes at birth. Okay. Then there are entrances into the heart from the coronary sinus carrying blood from the heart wall and other vessels. The right ventricle, a lot of this is repetitious. It might be good to go to sleep on, put you to sleep, but I'm going to go ahead and go through, even though it's very repetitious. The trabeculae carnae, this is not like the trabeculae in your osseous tissue and your bones, your skeletal bones. But this is different. It's irregular muscular ridges inside the ventricle wall. Trabeculae is very irregular, the trabeculae in a bone. Capillary muscles, these are the cone-shaped projections. That's what holds the chordae tendineae, that holds the cusps from going backward. Okay, because we want the blood to continue to flow in an appropriate direction throughout the body. Then there's the chordae tendineae, right? We just talked about that. The left atrium has pectinate muscles inside the atria, the auricle, and entrances from the pulmonary veins, an exit to the ventricle through the AV valve. The left ventricle has trabeculae carnae on the internal wall surface and two papillary muscles that anchor the chordae tendineae for those two cusps. And then there's a superior exit to the aorta through the aortic semilunar valve that we have looked at already. Here's the pulmonary semilunar valve, and then here's the aortic semilunar valve right here that we were just talking about. There it is. And the two papillary muscles with the chordae tendineae and the bicusps, the two cusps for the bicuspid left AV valve, the right AV valve with its three cusps and three papillary muscles. We're at slide 25, so we're about a third of the way through. Valves ensure one-way blood flow, right? Two types, the atrioventricular and the semilunar. Atrioventricular valves, these prevent backflow to the atria. The right and left AV valves prevent backflow. The AV valves close when ventricles contract. They force the blood superiorly. Papillary muscle and tendinous cords prevent inverting into the atria. So we don't want those cords that are coming from the ventricles. We don't want them to allow the cusps to go up into the atria, because then our blood flow would be disturbed. Semilunar valves, they also prevent backflow to the ventricles. Blood is forced through them when the ventricles contract, and then when the ventricles relax, they prevent the blood from returning. The blood pressure is higher up here, but it won't go back. It's like this, just it won't let it go back one way. Valvular insufficiency. Welcome to Saturday. Cardiac valves, they leak because the cusps are not closing tightly. This allows blood to regurgitate back through the valve, and this is going to contribute to heart enlargement. Valvular insufficiency, that means the valve is not sufficient. It's not working sufficiently. Valvular stenosis then is when the valve cusps are scarred from damage and they can't open completely. This causes resistance to the blood flow. It reduces how much blood can go through and how much output there will be, because there won't be as much to push. Coronary circulation delivers the heart from the wall. We saw those coronary arteries where a person might have a coronary artery bypass. Delivers blood from the thick wall. Coronary arteries transport oxygenated blood to the heart wall, and coronary veins transport deoxygenated blood away from the heart wall toward the right atrium. And if you have a chance to look again at the hearts, you'll find you can use a probe and stick your probe into there. There are branches, coronary artery branches. The right marginal artery is going to supply the right heart border. The posterior interventricular artery supplies the posterior left and right ventricle. The left coronary artery branches, the circumflex artery supplies the left atrium and ventricle, and the anterior interventricular artery supplies the anterior surface of the ventricles, most of the interventricular septum. These are interesting, and I think a good way to study that, if you want to pursue it, would be to get an outline of the heart in these areas and use a colored pencil and show where each of these are fed from and where they go. The person who needs a coronary bypass or a triple coronary bypass or quadruple coronary bypass, because they have these areas of occlusion, the same person and body that created the occlusions, without any change, it's going to happen again. So getting a bypass doesn't mean you're home free and it's good as new. It means all the other vessels are in the same condition as this one typically. And so that would be a warning to someone to, hey, change your lifestyle. Coronary veins, there's a great cardiac vein, a middle cardiac vein, a small cardiac vein, and a coronary sinus. Those are good to find. Here's that coronary sinus again that we saw earlier, the great cardiac vein, middle cardiac vein, and the small cardiac vein. Coronary heart disease. It's a buildup of plaque in coronary arteries. We call it atherosclerosis, and it does reduce the blood flow to the heart muscle. And reducing the blood flow is going to cause an extreme deficiency in oxygen and nutrients, so the heart will not be able to perform well if it performs at all. The coronary spasm is going to do the same thing. It's a sudden narrowing, and this might happen from a response to behavior, a response like to a drug that might cause that. Both of these can lead to angina. What is angina? Chest pain, maybe including the left arm, or a MI, myocardial infarction. Angina is the pain. The myocardial infarction is the noun. It's what happened to the heart. It's the dying tissue. Could be the causation of the dying tissue. Angina pectoris. Yes, heart pain during strenuous activity. No, remember that when a person is active, the heart rate goes faster because the cells in the body need more oxygen. They're using up oxygen, and maybe you incur an oxygen debt and you have to deep breathe for a while after you stop the physical exertion. With the extra requirement of oxygen, the angina pectoris may show up only on that extra exertion. And maybe when that person finally rests again, maybe the pain goes away. It's very serious. There could be an occlusion anytime. Then the pain and then the actual damage would be happening whether you were having an activity or no activity. Myocardial infarction is a heart attack. It is the sudden or seemingly sudden and complete occlusion of a coronary artery. So tissue death is going to occur and the cells are going to begin dying, and hopefully we'll give something there to open that all up before it's too late. Excruciating chest pain radiating down the left arm. There'll be weakness, shortness of breath, nausea, anxiety, sweating. Also the jaw. Okay, there'd be pain in the jaw as well, typically. And here you can see a example of what an occlusion might look like. And in reality, I think sometimes this looks like adipose here, but plaque. I think the plaque would be a little bit of everywhere usually. Now, if there's a torn place in the vessel or a damaged or a rough spot, it can happen in just one area alone. Okay, just because the blood, the cells, the formed elements are all whirling around there, and it'll cause difficulty. Here you can see that past the occlusion, there's no more nutrient and oxygen for the tissue. An anterior infarct. I'm going to take a short break since we're going to be starting the electrical system momentarily. We'll start the electrical system in a moment. Okay, we are electrical people. We're run by electricity and hormones, and these systems work together. So the hormones tell different parts of our body what to do. Hormones work slow onset and continue and a slow decline of those messages, okay? The electrical messages, the electrical signals that go through our body, these are instant on, instant off, okay? A lot different than the hormones. So let's talk about the cardiac electrical system next. The conduction system. It initiates, remember that node in the atria of the heart, and it conducts electrical events. For example, contractions of the pumping of the ventricles to ensure proper timing of contractions. Specialized cardiac muscle cells, they have action potentials, but they don't contract. The activity is influenced by the autonomic or autonomic nervous system. The autonomic nervous system takes care of events like digestion. We don't have to think and do, okay, digest. We don't. It's autonomic. It's automatic. Okay. And this is also autonomic. The SA node is going to initiate a heartbeat. The SA node is the pacemaker. It's in a high posterior wall of the right atrium. The atrioventricular node is in the floor. We've seen images of that, a few so far already, of the right atrium near the right AV valve. The AV bundle, or bundle of His, is where it goes next. It extends from the AV node through the interventricular septum, divides into left and right bundles. The Purkinje fibers come next, and they extend from the left and right bundles at the heart's apex, and they course through the walls of the ventricles. And here we can see the SA node, and it's going to be, as the pacemaker, it's going to fire, and these impulses are going to hit the AV node. And when the impulses hit the AV node, this impulse continues toward the interventricular septum where it divides. These are the bundle branches. And then it divides both ways into Purkinje fibers. And the Purkinje fibers then culminate at the edge of at the end of the ventricles. This is influenced, not begun, but influenced by the medulla oblongata. The medulla oblongata is in the very, very center in here, all the way in. Breathing is the vital things that we need to survive are way inside, okay? It's protected more on the inside. On the outside, we have this skull, okay? Well, we have hair for protection over our, but we have this skull to protect where our sensory information is, and then our speech is in here. All the way into the middle, we find cardioacceleratory and cardio-inhibitory centers in the medulla oblongata. This medulla oblongata receives both physical, the baroreceptor information, and also chemical, the chemical chemoreceptor information in the cardiovascular system. So those messages come from the cardiovascular system to the medulla oblongata. They come in through the sympathetic and parasympathetic pathways. Those also we don't have to try to make happen. It's an autonomic thing. So the medulla oblongata modifies, but does not initiate cardiac activity. The sensor may determine, wow, there's not enough blood pressure, and the medulla oblongata is going to say, speed up that heart rate. Okay, sometimes that helps, and sometimes it lets a person die. All right, but this is the way it works. Electrical conduction. Now let's start over again. Okay, the SA node cells, they initiate their autorhythmicity. That because of that autorhythmicity, they initiate a nerve impulse. It's a spontaneous firing. So we say nothing told it to fire. It just does it like a jumping bean. When it reaches a threshold, okay, the message more and more and more until a threshold is met. This requires sodium, potassium, calcium. So as the slow voltage gated sodium channels open and sodium flows in, there's a change from a negative 60 millivolts to negative 40 millivolts. And this is the threshold value. That's how much it takes. When you get up to threshold, you get enough to make a nerve impulse. You have to have enough electricity. So you can see that sodium has a positive charge. And so that's our electricity there, the positive charge, electrical charge. The depolarization then is when the fast voltage gated calcium channels open. The calcium flows in. The membrane potential changes from a negative 40 millivolts to just above 0 millivolts. When a message is sent, this is like the wiring in our house, but the wiring in our house is continually putting the action potential through the wire. It never, ever stops. The light is on, the computer's on. It's constant. But in our body, it's not constant. There was a threshold met. The electrical impulse went. And now there's depolarization. After depolarization, another message needs to go, repolarization, okay? So the calcium channels close, voltage-gated potassium channels open, and potassium flows out. The membrane potential is going to go back to where it was resting, the resting value. The resting membrane potential is a negative 60 millivolts. The voltage-gated sodium channels open at negative 60 millivolts, and process begins again. So we have a nerve impulse went, depolarization, repolarization, threshold is reached, and another nerve impulse goes. Okay? Questions, please put them in the comments below. I wish I could hear your questions now. If we were together, that would be great. But then you couldn't watch this on Sunday morning before your day starts. After starting at the SA node, the action potential spreads. Okay, we're going to go through it again. The action potential is distributed throughout the atria, where we have the SA node and then down to the AV node in the atria still, SA node, AV node. The excitation travels via gap junctions into the two, and the two atria contract together. The action potential is delayed at the AV node. The AV nodal cells are slow, and that's because it's a small diameter and few gap junctions. There's too much, it slows up. It has to get in line and go slower. Not enough room to get all of it through. Insulation of fibrous skeleton means that the AV node is a bottleneck. It's the only path. It's going to be slower. The delay is important because it allows the ventricles to fill up with blood before they contract. Action potential travels through the AV bundle to the Purkinje fibers, the AV node, AV bundle, bundle of branches, and the Purkinje fibers. The action potential spreads through the ventricles. The gap junctions allow the impulse to spread through the cardiac muscle fibers. Cells of the two ventricles contract nearly simultaneously. It's very important for the impulse to continue regularly, to continue as it needs to. You can see here as the pacemaker has sent the message also over to the other atria, so they can both contract together. And then down to here, and then this is where it slows up, allowing the ventricles to fill with blood before, boom, it has to push them out, push the blood out. The pump works. Okay. Depolarization again. The impulse from the conduction system or the gap junctions. It opens the fast voltage gated sodium channels. So we're going to have positive charge moving. The sodium enters the cell, changing the membrane potential from a negative 90 millivolts to a plus 30 millivolts. The voltage gated sodium channels start to inactivate. There's a plateau. The depolarization opens the voltage gated K potassium and slow voltage gated calcium channels. The potassium leaves the cardiac muscle cell as the calcium returns. This stimulates the sarcoplasmic reticulum to release more calcium. The membrane remains depolarized. All of this potassium involved with muscle contraction. It's also involved with skeletal muscle contraction. And that's how sometimes people with unoptimal calcium levels experience muscle cramps. So it happens. All right, here we go. Repolarization. This is when the voltage gated calcium channels close while potassium channels remain open. The membrane potential goes back to negative 90 millivolts. Pretty nifty, huh? And other places in the body, another one in my mind that we're going to be studying in several weeks, has this same rhythmicity to it. These I just put in for your interest to look at. Sodium comes in, woo! And then all this is happening and we're back to normal. And then it repeats and repeats and repeats. So, yeah, it's very exciting to realize that we've discovered this calcium is going through here. I added this one because sometimes we forget that it's actual cells. These are cells. That this is going on. There's a whole universe going on in here. So many things. Just, it's like a sci-fi. You found another universe somewhere. So much going on in there. We learn more every year. The electrocardiogram. This is useful. The ECG, EKG, either one. It's useful for diagnosing where the problem is in the cardiac cycle. You do need to know the aspect of the P wave, QRS complex, T wave, and then those two on the next slide we'll get to. To do an ECG, there are sticky contacts with a little bit of metal here because it's conductive. Okay, plastic and glass are not conductive. Metal is, some is. And they're stuck, maybe you have a 12 lead, maybe there are 12 stickers. Everybody's stuck to the person in specific places, okay? And hooked to a machine. The machine is going to read out something like this image on this slide. These lines, and maybe you've seen the lines used on t-shirts and things like that. They're very fun. So the P wave, and this is just a little wave, okay, a little wave. We wouldn't spill if we were on a canoe. And it reflects the electrical changes of atrial depolarization that happens in the SA node. So when you look at that printout from the machine and the P wave looks just right like that, you know that atrial depolarization that started in the SA node, you know that's working the way we expect it to. The QRS complex, the same thing, except what's going on. It's changes associated with ventricular depolarization and the atria repolarizing all at the same time. And that's what the QRS complex is displaying. The T wave is an electrical change associated with ventricular repolarization. So that's what's happening on this little wave. Okay, and then we're going to look at the segments next. Okay. There are two segments. The PQ segment, it's associated with the atrial cells plateau. While the atria are contracting, okay? Is that functioning well? We'll see that with the PQ segment. And then there's the ST segment, and this is the ventricular plateau. The ventricles are contracting. Okay, so through these two segments, the P wave, the T wave, and the QRS complex, we can determine what is functioning as we expect it to at those times during the cardiac cycle. So familiarize yourself with those. I believe there's a couple of items in that 1, 2, 3, 4, 5, 6, however many, half a dozen or so. A couple of them you need to remember. And then, you'll go through that in another class coming in the future. So you'll get that nailed better then. Electrical events of the heart on an ECG. So we have atrial depolarization, plateau, and repolarization. And this is exactly what we just went over on the prior slides. And the ventricles go through ventricle depolarization, ventricle plateau, and ventricle repolarization. And each of those, well, not the atrial repolarization, but the rest of it you can see on the ECG. The ECG is not going to display what's the atrial repolarization. The two intervals, the PR interval, this is the time it takes to transmit the action potential through the entire conduction system. Wow. The QT interval, the time from beginning of QRS to the end of the T wave. Ventricular action potentials, and the heart rate's going to determine how long this takes. Changes might result in tachyarrhythmia. And tachyarrhythmia is rapid, irregular heart rate. Tachyarrhythmia. Tachy is fast because it's tacky to be too fast. Very tacky. We'll get into that later. Cardiac cycle, all of the events in the heart from the start of the one heartbeat to the start of the next. It includes systole, the contraction, and diastole, the relaxation, and it's talking about the ventricles there. Contraction increases the pressure, relaxation decreases the pressure. The blood moves down its pressure gradient. So if the pressure gets really high in the ventricle, the blood's going to move up. That's down the pressure gradient. Okay. Squeezes the high blood pressure and it goes up. Valves ensure that the flow goes forward and their closure prevents the blood going backward. Ventricular activity is most important. Yeah, because that's forcing the blood to go where it needs to go. Yeah. And this is a repeat again. And it's good to be able to take an image of a heart, like we've seen already, and with your finger flow exactly. Let your finger flow where the blood would flow. And then imagine, okay, the valve is opening, the valve is closing. Okay. And this is a very detailed tracing of where the blood is going and what's going on while the blood is moving that direction. And that's good to review. End systolic volume and stroke volume are important to recognize. Ventricular ejection, that's the contraction of the ventricles. Stroke volume is the amount of blood ejected by the ventricle. The volume of the stroke, okay, the stroke volume. And systolic volume is the amount of blood remaining in the ventricle after the contraction finishes. Isovolumic relaxation. When all valves are closed, blood neither enters nor leaves, and the time is called isovolumic. Isovolumic. Some of these concepts are not in all anatomy classes. This one is ours, okay. Atrial relaxation and ventricular filling. This is when the whole heart is relaxed. Atrial blood pressure forces the AV valves open and blood flows into the ventricles. The semilunar valves remain closed since arterial pressure is greater than ventricular pressure. Equal amounts of blood are pumped by the left and the right sides of the heart. Both atria, both ventricles have to pump the same amount of blood, even though they're very much different in appearance. If they don't pump the same amount of blood, then there's a possibility of edema and or swelling. Cardiac output. Cardiac output is a measurement. It's the amount of blood pumped by a single ventricle in 1 minute. It's measured in liters per minute. I think you need to remember this. It measures the effectiveness of the cardiovascular system. Healthy people, when they work out, this is going to increase. And the cardiac output is going to be determined by the heart rate, the beats per minute, and the stroke volume, the amount of blood ejected per beat. So this much, this much, this much every beat, count all the beats for the whole minute, and times it by how much each beat pushed. Heart rate times stroke volume equals cardiac output. So if a person has a heart beating at 75 beats per minute, and there's 70 milliliters per beat, then it's going to be 5.25 liters per minute. Cardiac output must meet the tissue needs. People with smaller hearts, like women and children, will have a faster heart rate. Men and people who have a larger stroke volume will have a slower heart rate. Endurance athletes are going to be conditioned, and they don't have trouble with that. Their heart rate can be lower. Cardiac reserve. The capacity to increase cardiac output above rest level. Heart rate accelerates and stroke volume increases during exercise. This gives a measure of level. This gives measure of level of exercise an individual can pursue. People that are in condition can increase that more. If you think back several slides back, and we talked about people who had chest pain on exertion, yeah, they have a harder time as well with exercise. Gives measure of level of exercise and an individual can pursue. Yeah, so heart size, heart condition both. Chronotropic agents, these change the heart rate. Activity, after the activity of nodal cells, SA and or the AV node, often work via autonomic nervous system or hormones. Hormones rule. They are chemicals needed in tiny, tiny, tiny amounts. And yes, they're slow to set on their onset. They continue for quite a while and they're very slow to stop. And they do make large changes for their tiny quantities. Positive chronotropic agents increase the heart rate, the sympathetic nerve stimulation, and this is going to be causing norepinephrine release on the heart, causes the adrenals to release epinephrine and norepinephrine. Receptors are beta-1 adrenergic receptors, G protein, adenylate, cyclase, CAMP, protein kinase, cascade. Phosphorylated calcium channels enhance calcium influx, so cells fire sooner. Your body makes more drugs than there are at the drugstore. This is not, this is helpful. The body's reacting this way to help us, but we don't want to be in those situations that cause this to be continual, or it will. Some people say, like, wear out the adrenals. You don't want to actually always be pushing them. Positive chronotropic agents. Thyroid hormone. Thyroid hormone affects every cell of the body. If you have too much, it will make a revved up situation in your body. If you don't have enough, you'll tend to fall asleep, be lethargic, depressed. Yeah. Very, very, very low perk if you don't have enough thyroid. But if you have thyroid hormone, it's going to work this way to rev the person up. Okay. Caffeine inhibits the breakdown of CAMP. Caffeine does a few things. Nicotine. Cocaine. Again, stroke volume is the amount of blood ejected in one beat. Stroke volume is influenced by venous return, inotropic agents, and afterload. Venous return, this is the volume of blood returned to the heart, and it's directly related to stroke volume. It determines the amount of ventricular blood prior to the contraction. That is end diastolic volume. Volume determines preload. Pressure stretching heart wall before shortening. Venous return. You do need to be familiar with the Frank Starling law. You're tested on that next week. I think that's Tuesday's the test. You have to know that. As EDV increases, the greater stretch of the heart wall results in more optimal overlap of thick and thin filaments. Thick and thin filaments, okay? Heart contracts more forcefully when filled with more blood. So the SV increases. Venous return might be increased by increased venous pressure or increased time to fill. Venous pressure increases during exercise as muscles squeeze veins, even walking. Time to fill increases with slower heart rate, for example, in high caliber athletes with strong hearts. Venous return decreases with low blood volume. If there's a hemorrhage or a high heart rate. Less blood in the venous system. So, yeah. Results in smaller end diastolic volume. Preload results in smaller stroke volume. Balanced ventricular output due largely to the Frank-Starling law. As one side receives increased blood volume, it contracts more forcefully, leads to greater fill and more forceful contraction on the other side. Okay, what is afterload? Resistance in arteries to ejection of the blood by ventricles. Pressure that must be exceeded before the blood is ejected. Atherosclerosis or plaque in the vessel linings increases afterload. This is seen with aging and heart disease. We don't have time to talk about what causes that. We're on slide 70. Smaller arterial lumen exerts greater resistance to movement of blood, just like a half-inch garden hose compared to a 1-inch garden hose, or a 10-gauge wire compared to a 16-gauge wire. It results in decreased stroke volume. Sarcomere lengths. Yeah, they stretch and shrink. You have actin and myosin, they go right past each other. There's a actual physical moving of one past the other, okay, but there's a bunch of it. So contraction, strength. It increases. We can measure in time the contraction starting and stopping. Cardiac output directly varies with heart rate and stroke volume. Again, same formula. Heart rate depends on chronotropic agents, the influence of the SA node to change its firing rate, the influence of the AV node to alter the amount of delay. Stroke volume generally depends on the state of myocardium. The venous return alters stretch of the heart. The inotropic agents influence the cross-bridge formation. End diastolic volume is the measure of blood in the left or right ventricle before the heart contracts. And systolic volume is the volume of blood in a ventricle at the end of a contraction. Okay. Old people have more afterload. That decreases stroke volume. Old people are on low perk. It's not the age. It's not the age of the person in chronological years. It's the aging done to the body because of 80% environment, behavioral, and 20% genetic. Okay, we attribute stuff to genes that it's because we have Snickers for breakfast. Bradycardia and tachycardia. Bradycardia is when the heart rate is too slow because Tom Brady is slow. Persistently low resting heart rate in adults, below 60 beats per minute. This is a normal change in athletes. Okay, bradycardia, slow heart rate. This might be because of hypothyroidism that we mentioned earlier, causes somebody to be on low perk, tired, very tired, very tired. Yeah, depressed. Electrolyte imbalances can cause this, and congestive heart failure. Tachycardia. It's tacky to be too fast. Tachycardia is a persistently high resting heart rate that's over 100 beats per minute. And this may be caused by heart disease, fever, and anxiety. Yeah. Wow. Okay. Sharing has stopped. Perfect. All right. Well, I hope you have questions. Some of that I ran through. Please ask questions in the comments, and I'll answer them as well as I can, as soon as I can. Thanks.